So good morning. So thanks, Alan, for the great talk. We really enjoyed the Mickey Mouse story. I mean, the way you have shared the principles was very great. We have to see how do we kind of uh, replicate them in our system. So here, thanks again, for Venkatesh to organize this workshop for our alumni. I mean, I also made the talk so that our alumni will get the benefit out of replicating or doing what we do in Aravind. So I'm sharing some of the best practices so that we are able to deliver the best care for our patients. If you have to use the word, what Alan used, it's to our guests. So move on, Martin. Yeah. So, we all have one challenge, whether it is a institute or a single practitioner or a group practice, we all have only one challenge in our practice, which is how do we grow the volume of patients? That is fundamental, whatever work we do. So unless we grow the volume of patients, we are not going to have a sustainable practice. And again, this growth has to be done in a very sustainable processes. Only then, it will also stay for, sometimes you can do a mass media advertisement and all that to get a large number of patients, but it is not going to sustain. And once you are able to have enough patients, it takes care of your financial needs. It's all able to bring out. When you have really good volumes, you are able to really get the best out of your staff. The efficiency, the effectiveness of the staff also improves. And also it helps in overall sustainability of the whole organizations. So when you want to really grow the volume, what you really need is how do you develop the community's faith and building trust. The talk which was given by Alan was all about that. Now, how do we give them a really good experience? How do we treat patients as a guest? So, and this concept of not having waiting chairs or a concept of not a waiting room is really great. Just a lobby and make sure that, and one of the thing he says that, his KPI or key performance indicator, how well he is doing is that no patient should be waiting there. So he constantly monitors the lobby, how many people are waiting there for a certain period of time. So it's all of that, if you want to do all of that, it really comes out of empathy and compassion and the way we do our processes in a transparent way. How do we treat everybody equally and equally importance? As we give that thing, we also need to make sure that we provide good medical and nursing care. The quality also becomes very important. And it's also important that, that we ensure all aspects of quality because, ophthalmology, the patient touched several points. Maybe in Aravind, maybe 10, 12 people are touched during the process. And each one, each practice, it becomes different. But what is important is that you should be able to provide all aspects of quality at every interaction. So one, if you really want to build culture in your practice, you have to really understand the elements of quality. Your staff have to understand the elements of quality. That's again another point which Alan really stressed about staff education. He was talking about even teaching and training the staff, all the aspects of the clinical protocol, with the preferred practice pattern so that they really understand the whole of the ophthalmology. So this is a simple framework that will help people to understand, which is when you talk about quality, these are the 6 elements. One is the safety, patient-centeredness, effectiveness, efficiency, timeliness, and equity. So for this talk, I'm going to just covering only the first 3, which is the safety, patient-centered care, and effectiveness. And if you talk about safety, which is the most important thing, and it forms the base of the whole quality. Without that, you'll not be able to build a sustainable practice, which is relates to not harming the patient, treating the correct patient, correct site, correct treatment, and making sure that the system is error-free and there is a safe facility. So we'll see a little bit of that. And then if you look at the quality perception of the patients, I also go back to Prajana's talk. You was telling that people at the age of 25, they are not thinking about saving. Similarly, either the patients always talk about reliable services, appropriate cost, transparency, how they are being taken care in the system. Whereas the providers are really, look at, how do we ensure good outcomes, minimizing conflict. It's all about how do we give effective and make sure the patient gets the best. And also they are interested in using best-in-class technology. but neither the patients nor the providers don't have the safety issues in mind. So we all know that in ophthalmology, with both the eyes and being a very complex, as the ophthalmology, like any other medical field, healthcare, it's evolving. There are multiple choices for treating a patient. If you want to give intravitreal anti-VEGF injection, you've got 5-6 type of injection. Cataract surgery, there are 4 or 5 type of surgeries, and multiple ways, you can put the different intraocular lenses. And all of these are issues, which we have in safety issues. It could be a wrong eye surgery or a wrong procedure, wrong IOL power design. And not only that, you also have vision-threatening complications and infections, and also being a majority of them being old, we also have systemic, instances, morbidity, mortality, pulmonary edema, infarction. All of that, we are in a situation where we have to really ensure safety. So understanding what can go wrong is also very important, not only for you, but also the staff should really understand the exceptions, we call it, what can go wrong and how do we make sure that doesn't happen. And this is a publication from this published in Survey of Ophthalmology, where they talk about the instances that have been reported from 900,000 consecutive surgeries done in New York. And they say that one kind of incident, like a sentinel event, we say happens 1 per 15,000, and many of that could have been avoided if they followed a safety protocol. So here now we are not talking about something that happens every day, but something that happens maybe once in your practice, once in your lifetime, which can change the whole way you have the further future of your practice. So, and again, it's again important that you have a clarity on the safety goals. And each practice, it can be different. What we have put together here is the safety goals we have identified for the whole Ravindran Eye Care system. And again, I would like to say that the whole safety part, what can go wrong in Aravind may not happen in your practice, because it's all related to the work process. And creating a system that enhances patient safety is very important. But I'll touch upon some of the common ones, which will be also relevant to all of us. One is the patient identification protocol. You must have a clarity how you are going to identify the patient. Yesterday, Alan, in a workshop, he was mentioning about when something is wrong. When he's trying to talk to the patient, if something is wrong, the right patient is not there, how he will handle that kind of situation. So we have to make sure that even if you're efficient, Alan sees up to 100 patients a day. But he mentioned very clearly that doesn't compromise on the safety or identification of the patient. So whether it's an OPD or an inpatient, you have to have systems wherein you'll be able to identify your patients. And again, identifying the eye we are going to operate or you're going to do the procedure. It can be anything, it can be single marking, double marking, whatever way. And having a safety checklist and making sure that people really understand, not only you, but the staff, everybody is working with you. And again, timeout in the OT. Like Aravind, we have a timeout not only in the operating table, but at least at 3 or 4 locations, where you have to clarify what you are going to do. For example, it can be patient's name, medical record number, and whether the marked eye is correct. So we look at that not only the outside the OT, inside the OT, and also during the surgery when we are going to do the implantation of the IOL. So these are some of the practices. And again, we had time and again we had seen a blocking, giving an anesthetic block in a wrong eye had been an issue. And once we have a paramedical person or somebody else stay with the doctor when they give this block, we were able to control this. Leaving one person to do any crucial act is not safe. So it's always, if there are 2 people there, and you'll be able, the chances of making a mistake becomes very, very less, and both have to be involved in that process. And again, this is one area where we don't pay much attention, which is calibration of equipments. If you don't calibrate them on a regular periodical intervals, one day you may end up in some trouble. So these are some of the things. But what is equally important is that across the system, whatever your practice, 10, 12 people or 20, 30 people, there must be a culture of reporting. And then how do we empower staff, and give them that courage to report is very important. And there is a simple incident reporting system we have in the organization. So each year, probably in a place like Madurai, we may have about 800 to 1,000 incidents reported. But it captures all minor, major, everything is there. And making sure that the staff the whole system understands that everybody have to be involved is very important. And again, coming back to the talk given by Alan, it's all about patient-centered care. If quality is to be at the heart of everything we do, it must be understood from the perspective of patients. So whatever we do, we have to keep the patient in mind and design the whole process. So it's important because each patient interaction is very important. It's not just about the doctor or the provider, but everyone in the system, right from the person who receives the patient, like the security, to the doctor or the person who counsels the patient after you see them. And here we have put together certain goals. So these are some of the guiding principles. I'm not going into that. It's about how do we create access for the patient? How do we make sure that we maintain the dignity and being responsive to the patient's needs? How do we enable the patients to make informed decision making and getting a proper informed consent? There must be a transparent pricing, and how do we minimize the cost of treatment? And how do we ensure follow-up of all the patients, ensuring that all the amenities are there? And and how do we handle any complaints? Where a simple principle that patient is always correct. If that goes to the staff, then many things can be addressed. And also having a place of continuous improvement. But if you really want to be patient-centered, you need to collect all the data and look at not only the reasons why the patients are happy, and also this is for the patients, for the reasons for satisfaction, and also reasons for dissatisfaction. Even though the numbers may be very small, this is what you have to really address. As Alan can see that the real problem is the waiting time everywhere. Anywhere you see the patients are not satisfied, it's usually the waiting time. And again, when there is a problem, and it's always good to have a group discussion from the patients, bring together some of your patients, discuss with them what is it they're expecting from us. And again, it would be good to track your online reviews. Each hospital, every practice, if you are doing a reasonable volume, and you'll be able to see how people rate you. And again, the last part of my talk is about effectiveness. Its effectiveness is about how do we ensure good outcomes, and also ensure that you minimize the complications. So basically, this is about that. And if you want to be really effective, you need to have clinical protocols for all the areas where you're handling. He talked about the preferred practice pattern, and not only it's about you, but all the staff in your department, in your clinic, should be aware of that. And it's the second important thing is how do we train our staff? Okay, it's not only just the doctors, but also other staff, and there must be a way of scoring them, whatever they do, how effectively are doing the training. For the cataract surgery, we are all familiar with this Oscar scoring. For the MLOPs, we use a rubric. Now we have come up with a test work instructions. Based on the work instruction, we have created a rubric, and we make sure that here you can see that they were, when we are assessing somebody on visual acuity, we assess them on nearly 25 patients before they actually do go through a final examination. And again, if you have to do the regular monitoring, 1 second. So monitoring review is very important. Sometimes in an organization like ours, we have put together a registry wherein all cataract surgeries, everything gets, or the details of all cataract surgery is entered into a registry, and we are able to create a outcome monitoring sheet wherein we can monitor the intraoperative complication, post-surgery complications, visual outcomes, how many people came for follow-up, the biometric details. All of that will be able to, some kind of a system you need to have, otherwise you'll not be able to make. Because once you are able to track, you can optimize some of the clinical testing. We went from applanation to immersion based on this evidence we got from here. And just providing the data to the doctors and understanding what goes wrong, we are able to also bring down the complication rate. You can see that the 10 years back was 1.19. Today we have between about 0.7 to 0.8. And this also gives you an opportunity to benchmark yourself with other published data from the international organizations like UK National Database, European Cataract Database. So all of that, you'll be able to benchmark and see where you are, and you can try to be better. And it's also, to effective, it's also about bringing in evidence-based practices. One such thing, what we have done in Aravind is adopting intracameral antibiotics. This intracameral antibiotics is there for a long time. People have been using it from 1990. So this is a paper that was published in around 2000, wherein the Steve Orshinov showed, combined all the papers and showed the effect of having intracameral antibiotic and the difference it made in bringing down the rate of endophthalmitis. And this was very compelling evidence, and few years time we were able to adopt, and we were able to, because a proper commercially available drug was not available. We really worked with Oral F for 2 years to bring out this drug. And once we started using that, we were able to show that there is a 4-fold reduction in endophthalmitis. This first paper was done in our free patients, where the incidence was slightly higher because of the technique we also use. In the SACS, it's slightly higher than what we have in phaco. And we were able to show a definite decrease. And then we kind of scaled it up across the system. So this, as you can see here, up to 2015, you can see, there has been the rate is around 0.70, 0.07 to 0.08, which is like 7 to 8 patients develop endophthalmitis per 10,000 surgeries. But even though the volumes have increased, after we started using that, it has come down to 1 or 2 per 10,000 surgeries. So this has been made a remarkable difference. For example, in 2021, where we have done 317,000, if our rate had remained like what it was earlier, then we would have had somewhere around 270 to 300 patients with endophthalmitis. Managing them would have been really a major task. And again, also will close with this one thing where we have brought in a change for the information for our alumni is, all of you are aware that we have been using retrobulbar and peribulbar anesthesia, and it has got its own complication, even though it is less, it varies from 0.006 to 0.01%, 13%. And the complications could be retinal break, subretinal hemorrhage, all of that. Sometimes if you're going to inject anesthesia into the globe or into the nerve, it is really catastrophic. And as you can see here, we have been the 3 years data. You can see that we have about 13 patients who developed globe perforation, and 2 of them developed central retinal artery occlusion following peribulbar, retrobulbar anesthesia. And one instance we had in 2016, where in one hospital, one doctor produced 5 or 6 globe perforation over a period of 7 to 10 days. So now that made us think, then if something like this is going to happen again in another hospital, it's not acceptable. And that's when we switched over to subtenons. So we initially started with our paying patients. As you can see, we went, the month we tried using, we checked whether it is possible or not. We were able to give it nearly in 40% of the patients. The next 3 months, we went from there. Almost, if you can see the retrobulbar, within 3 months, it dropped less than 5%. Across, it's about 4.7% in Madurai. So then we scaled it across all the hospitals. And last year, you can see it was only 0.3%. So majority of the patients received subtenons or a topical anesthesia. As a result, you can say that last 4 years, we don't have any globe perforations or any retinal artery or vessel occlusion. So I mean, adopting what is existing, changing, understanding, or not accepting even a lower level complication is also very, very important, and making changes in your practice is very important. These are some of the values, ensuring safety, keeping patients in the center as you design your systems and policies, monitoring outcomes, and again, bringing in evidence-based practices and adopting new practices is all important. And equally important is, how do you align the staff? One is having systems and processes, but if you don't align your staff, if you don't have the staff really understand the value behind the change or the system, we will not be able to make continuous refinement. Only if the staff really understand the human values behind the processes. When like yesterday, Tulsi was talking about purpose driving the organization and developing systems. But if you forget the systems, will run the organization. So unless we take a pass and understand the value system, we may not be able to make a progress. And here again, shared leadership model becomes important. So quality is something, it's not to be driven by the top, by few people, but how do you bring together a group of people, take ownership for the processes and the outcomes and the patient satisfaction in their own area. I think if you are able to bring them together in a hospital like within Aravind, each hospital there is a team not only for safety, for several other areas of quality, but they also meet across the system and share for a better thing. So this I feel, whether it's a small or big practice, involving everyone in your system becomes very, very important. Thank you.